Good evening to all. First of all, I thank the extracorporeal group and Georgina and sir for giving me an opportunity to speak on this forum. I also thank Binu Bendran sir for giving me those kind words of introduction. So, pregnancy-related AKA, it's not very common these days, but one time or the other, we all might have landed up in severe pregnancy-related AKAs, which causes trouble most of the times. So, I'm going to just brief to give an overview about the topic. So, about this topic, it's a heterogeneous disease entity which occurs due to a multitude of underlying etiologies. The problem is that it can cause significant maternal and fetal morbidity and mortality. And about the epidemiology, over the past few years, India has revealed a sharp decline in the proportion of pregnancy AKI, and it has reduced from 15% in the 1980s to 1.5% in the 2010s. And there's a shift in the time period at which it is happening. It's mainly because of the reduction in septic abortions mainly. So mainly the most of the AKs occur in the post-abortal period nowadays compared to postpartum. Now it mainly occurs in the postpartum period rather than the post-abortal period. Despite this, in the developing countries, pregnancy-related AKI account for around 5 to 20% of total AKI population. So this is an Indian scenario which is published by Prakash et al. In the Indian Journal of Nephrology. So here, if you look at the incidence of pregnancy-associated AKI, in 1980 to 1990, the incidence was 15%, whereas in 1992 to 2000, it reduced to 10%, whereas in 2003 to 2014, the incidence of pregnancy AKI reduced to 4.6%. So before we have to understand, before understanding the topic, we need to know about the renal physiology in pregnancy. So we know there are a lot of physiological as well as anatomical changes which happens in pregnancy. Mainly, the kidney size increases, the kidney volume increases by up to 30%, the length increases by 1 to 1.5 centimeter. So what happens basically is that pregnancy is a state of smooth muscle relaxation, which is due to the effect of hormones like progesterone. And because of this, there's something called as physiological hydronephrosis of pregnancy, which commonly affects the right ureter compared to the left. So due to the smooth muscle relaxation effect of progesterone, there is dilatation, and due to the acute angulation of the right ureter, due to acute angulation with the pelvic brim as well as the iliac vessel, the right ureter is more prone to develop hydronephrosis compared to the left. And about the physiological changes of pregnancy, the thing is that pregnancy, it's a state of reduced systemic vascular resistance. This is because in pregnancy there is end organ resistance to the effect of vasoconstrictors, as well as vasodilators are increased in circulation, mainly the hormones like relaxin. Because of this, the plasma volume increases. There is dilatation of the afferent as well as efferent arteriole. So there is renal blood flow increase. The renal blood flow increases by around 80% above the baseline. And because of this, the GFR also rises. It rises by around 50% above the baseline. Because of this, the serum creatinine reduces to around 0.4 to 0.6 in pregnancy. Uric acid also reduces to around 2 to 3, and it peaks. It reaches a nadir by around 22 weeks. After that, due to increased tubular urate reabsorption, the uric acid continues to rise, and the blood urea nitrogen levels are also low as 8 to 10. And there's a new osmotic set point and a new thirst threshold of 270 milliosmol per kg. Because of this, the serum sodium is always low in pregnancy. So, how to diagnose AK in pregnancy? This is a very common problem which we all encounter. The main criteria is like rifle, akin, and KDIGO. So these diagnostic definition is not uniform, and these criteria can't be applied in the pregnant population because it is not validated according to studies. And what is the problem in identifying pregnancy-related AK? The thing is that, which I mentioned previously, there's a physiological increase in GFR by around 50 to 80% and increase in plasma volume. Because of this, even a normal serum creatinine in pregnancy should be considered abnormal because it can easily mask mild AKI. So what about the EGFR equations in pregnancy? Studies have shown that the MDRD, cockroach cold, as well as the CKD EPA population, they have not been validated in a pregnant population. As like in the other CKD other population in which the GFR is more than 60, the MDRD as well as
நான் கிளாஸ்ல இருக்க அப்புறம் வச்சிரேன் பாய்
the MDRD as well as CKD EPI, they underestimate the GFR in pregnant population. Because of this, 24-hour urinary creatinine clearance, this is found to be the best available correlate for GFR in pregnancy. So how to diagnose pregnancy-related AKI? The consensus, there's no consensus definition, but this criteria can be used for practical purpose. Any one of the three: sudden increase in creatinine more than one, there is oliguria or anuria, or the need for dialysis. So going on to the causes, we can divide the causes of AKI as like any other causes: pre-renal, intrinsic renal, and post-renal causes. The pre-renal causes, we mostly due to hyperemesis gravidarum, sepsis, which can happen in the post-abortal, puerperal or urosepsis, heart failure, medications like diuretics as well as NSAIDs, and the intrinsic renal causes, which are the most important. The most common cause is acute tubular necrosis or acute cortical necrosis, which is due to a pregnancy specific acute catastrophic obstetric hemorrhage due to abruptio placenta, uterine rupture, or due to sepsis, or due to the pregnancy specific conditions like preeclampsia HELLP syndrome, TMA, which can be TTP or atypical HUS, or acute fatty liver of pregnancy, lupus nephritis or antiphospholipid syndrome, pyelonephritis, as well as all other intrinsic renal causes which can happen as like in the general population. And we should not forget the post-renal causes, mainly hydronephrosis due to uterine compression, obstruction due to stones, iatrogenic injury during cesarean section or vaginal delivery, and spontaneous injury to the bladder or urethra during vaginal delivery. And this is a very important slide which I should be mentioning. So based on the timing of pregnancy AKI, we can have an idea about the etiology. So the septic abortions usually happens in the first 16 weeks or in the first trimester. And the abruptio placenta or severe hemorrhage or DIC usually happens after 24 weeks and up to the immediate postpartum period. Sepsis can happen after 16 weeks up to the immediate postpartum period. And the preeclampsia or HELP typically occurs after 20 weeks and it can extend up to delivery and up to 4 weeks postpartum. And the acute fatty liver of pregnancy usually happens late in pregnancy in the third trimester, usually from 28 weeks, and it can extend till delivery of the fetus. And about the TMAs, ADAMTS13 deficiency TMA, this time period is very important. It happens in the second and third trimester and up to first 4 weeks postpartum. Whereas the complement dysregulated TMA usually happens in the postpartum period. And any TMA of any unknown mechanism can happen throughout pregnancy after 8 weeks of pregnancy. Sorry, my slides. Okay. So what about the role of kidney biopsy in this situation? So the thing is like there's common clinical and laboratory findings are there in several causes of pregnancy AKI. So the exact etiology may not be elusive despite extensive laboratory and radiology testing. So it is told like a kidney biopsy should be done only if the biopsy diagnosis can potentially change the treatment. That is if you are going to give plasmapheresis or if you are going to give steroids based on the particular biopsy finding, then only we should proceed with the biopsy. And usually in the third trimester, it is usually avoided unless it results in a significant change in treatment. So going on to the AKs in each trimester, first trimester AKs. There are two common causes. One is pre-renal azotemia from hyperemesis gravidarum. Second is sepsis due to septic abortion. So hyperemesis gravidarum. Mainly it causes persistent vomiting, volume depletion, which leads to AKA. Typically there is metabolic alkalosis. The symptoms of hyperemesis are often aggravated by strong odors, hot food, and delayed gastric emptying. And the treatment is hospitalization, supportive treatment, IV fluid, antiemetic treatment. And about septic abortion. In sepsis, the cause of AK is multifactorial. It can be due to volume depletion. Second, it can be due to hypotension from hemorrhage or sepsis. And some abortifacients like soap or some disinfectants, they may have some specific nephrotoxic effects. So the manifestations are like any other features of sepsis, like abdominal pain, vomiting, jaundice, and labs will show anemia, leukocytosis, thrombocytopenia, oliguria, electrolyte imbalances. The most common histological finding in septic abortion is acute tubular necrosis, whereas acute cortical necrosis can also occur. So management is mainly supportive, administration of antibiotics, volume resuscitation, supportive treatment, if indicated, dialysis. So going on to the late trimester AKs. So mainly, we need to understand the spectrum of hypertensive disorders of pregnancy. It can be classified into 5 categories basically. One is chronic hypertension, which if the hypertension is detected before 20 weeks, if it is detected after 20 weeks, then it is preeclampsia. If it is associated with seizures, then it is eclampsia. And also there is something called gestational hypertension along with preeclampsia superimposed on chronic hypertension. So we are mainly focusing on the preeclampsia and the health part. So what is preeclampsia? Preeclampsia is characterized by new onset hypertension, that is a BP of more than 140/90 on at least 2 occasions, and along with proteinuria more than 300 milligram, which appears after 20 weeks of gestation. In the absence of proteinuria, any of the target organ involvement can also be taken as preeclampsia. Eclampsia is when preeclampsia is associated with seizures. So what is meant by severe preeclampsia? Severe preeclampsia is when systolic BP is more than 160 or diastolic BP more than 110 on 2 occasions at least 4 hours apart while the patient is on bed rest, along with any of the features of target organ involvement like platelet count less than 1 lakh, elevated liver enzymes, renal insufficiency, pulmonary edema, or new onset cerebral or visual disturbances, along with severe persistent right hypochondrial pain. So I'll be just dealing with the preeclampsia and HELLP syndrome part. Basically, what is a pathogenesis? So as we know, preeclampsia, it is mainly a disease of the placenta. Once the placenta is expelled, the preeclampsia, the disease tends to go into remission. So the first stage is like there is deficient uterine spiral artery remodeling. So the first step is there is placental ischemia due to spiral artery deficient remodeling. We'll see what it is. See here, this is the top part is what happens in a normal pregnancy. Here what happens is like the invasive cytotrophoblast of the fetal origin, they invade the maternal spiral artery. So what happens is like after this invasion, there's a change of the cytotrophoblast from epithelial phenotype to an endothelial phenotype. This is called pseudovasculogenesis or vascular mimicry. So this process is extremely important for converting the high resistance low capacity vessels to a low resistance high capacity vessels so that the blood flow to the placenta is increased for meeting the demands of the fetus. But what happens in preeclampsia? Here, this pseudovasculogenesis or this conversion of cytotrophoblast to an endothelial phenotype is impaired. So this does not happen. So what happens is like the spiral artery remains like a high resistance low capacity vessels, which results in placental ischemia. So this is the basic pathology which happens. And the second stage is like due to the placental ischemia, it leads to the consequent release of anti-angiogenic factors such as SFLT1 or soluble VEGF receptor 1 or soluble endoglin 1. This leads to generalized endothelial dysfunction. So this generalized endothelial dysfunction is the reason for multiple organ damage which happens in preeclampsia. So let us see what happens. So this is what happens in a normal pregnancy. Normal pregnancy, there is vasodilation. So for that, what we see here is VEGF and PAGF. So normally VEGF and PAGF binds to their receptors on endothelial cells so that their binding brings about vasodilation of the vessels. But in preeclampsia, what happens is this small thing. Now this is SFLT1. The fraction of this SFLT1 increases. This prevents the VEGF and PAGF from binding onto its receptors on endothelial cells. Thereby, the normal vasodilatation does not happen. This results in vasoconstriction and thereby extensive endothelial damage. So preeclampsia, there can also be an immunological and environmental factor together with genetic predisposition. So the renal lesions, as we all know, the lesions, it's called glomerular endotheliosis, which is characterized by swelling and detachment of glomerular endothelial cells associated with a subendothelial deposits, which leads to capillary luminal obstruction. So the most common picture biopsy histological lesion is acute tubular necrosis. There can also be renal cortical necrosis can also occur. So management of preeclampsia, as I told, placenta is central to the pathogenesis. So whenever there is severe preeclampsia, the management should be focused on delivery of the fetus. So maternal BP control along with pharmacological and non-pharmacological treatment. We have to assess the fetal well-being through color Doppler, non-stress test and Doppler velocimetry. Delivery is the ultimate treatment for this condition, but the timing of delivery is based on main factors like gestational age, maternal and fetal condition, as well as severity of the disease. So prompt delivery is indicated when there is worsening maternal condition. So next is HELP syndrome. HELP means hemolysis, elevated liver enzymes, low platelet. So this is considered a variant form of severe preeclampsia. There is significant liver involvement, but the thing is like in 20% of patients, they may have neither hypertension nor proteinuria. And there are features of help like hemolysis, anemia, decreased haptoglobulin, raised LDH, elevated liver function, low platelet. The first abnormality to be detected is thrombocytopenia. So the help diagnosis, as I told previously, microangiopathy, hemolytic anemia, along with cystocytes, along with raised LDH, increased transaminases, and low platelet count. So the management of HELP is also supportive care. Once there is HELP syndrome, timely delivery, it should be done based on gestational age and overall maternal fetal condition. And dialysis is needed in approximately 10 to 46% of cases. But the good thing in with HELP syndrome is that majority of the patients, they have near complete reversal of renal function, except in those patients who have some pre-existing renal diseases. So about the TMAs of pregnancy. Pregnancy TMA contributed to around 8 to 18% of all cases of TMA. It can happen, TMA in pregnancy can happen during any time. It can happen during pregnancy or at puerperium. And the thing is like it may occur de novo with pregnancy, it may relapse during pregnancy or may recur with subsequent pregnancies. So the TMAs in pregnancy classified as two types. One is TTP due to deficiency of ADAMTS13. Second is atypical HUS, which is a complement dysregulation related TMA. So what is TTP? TTP, as we know, it's a pentad of 5 things. One is fever, severe thrombocytopenia, microangiopathic hemolytic anemia, and predominant neurological symptoms. And kidney dysfunction is only mild renal dysfunction is only present in TTP. TTP is often diagnosed before delivery. It happens in the second and third trimester. There are two reasons mainly for this. As we know, TTP is mainly due to defect of ADAMTS13, which is a von Willebrand's factor cleaving protein. So by the second and third trimester, what happens is there's a progressive decrease in ADAMTS13 activity normally, along with a steady plasma increase in von Willebrand's factor during normal gestation. So this predisposes the patients to high risk of TTP during the late second and third trimester. And some data suggests that the monitoring of ADAMTS13 levels during pregnancy may help to identify patients who are at risk of TMA relapse. And there are even some studies which show like those patients who are ADAMTS13 deficiency, we may even transfuse plasma to maintain an enzyme activity more than 10%. And about atypical HUS. So it's mainly the complement mediated HUS, which is due to dysregulation in the complement pathway. Compared to TTP, the thing here is like the renal involvement is more severe, but neurological manifestations are less. So atypical HUS compared to TTP, this happens mainly in the first 6 months postpartum. And pregnancy, delivery, all those things are usually uneventful in majority of the patients. And while evaluating in more than 80% of the patient, we found some evidence of complement pathway dysregulation. So what happens is like infections and bleeding, which frequently complicate the postpartum period. This trigger the complement activation, which leads to TMA. And for those who have whom we find some pre-existing complement dysregulation, we can counsel them. One is like if it is complement factor H and C3 mutation, the risk of recurrence of TMA is highest, which is 20 to 30%, whereas the risk is lower in complement factor I and MCP mutations. Next is acute fatty liver of pregnancy. So AFLP, it's basically an obstetric emergency. If it is left untreated, it progresses to fulminant liver failure. And this also happens after 28 weeks of gestation in the third trimester. So there is basically sudden onset of acute liver failure along with coagulopathy. So pathogenesis. AFLP, it is basically due to a deficient fetus. Because the fetus does not have this particular enzyme called LCHAT, long chain 3-hydroxyacyl-CoA dehydrogenase. This enzyme is involved in the mitochondrial fatty acid beta oxidation. So because of this defective beta oxidation, there is an excessive accumulation of fetal fatty acid, which spillovers to the maternal circulation, which gets deposited in the maternal hepatic tissue, thereby it causes macrovesicular steatosis and liver lipotoxicity in the mother. So the symptoms are, it can be non-specific along with malaise, fever, nausea, vomiting, and abdominal pain. With progression, it can present with jaundice and hepatic encephalopathy. There's prolonged prothrombin time, depressed antithrombin 3, all these can lead to coagulopathy. And hyperbilirubinemia, hepatic transaminases can be increased, hypoglycemia, leukocytosis, all these can be present in AFLP. So there are two DDs when a women in third trimester presents with acute fulminant hepatic failure. One is viral hepatitis, that should be ruled out. One thing is like hypertension is present in around 25 to 50% of AFLP, whereas in viral hepatitis, hypertension is not present. And before diagnosing, we should rule out viral hepatitis as well as biliary obstruction. So the AK in AFLP is also multifactorial. It can be due to hypovolemia, coexisting preeclampsia can be present. It can be due to coagulopathy, hepatic failure, intra-abdominal hemorrhage. And usually the AK in AFLP is mild and usually does not require dialysis. And if at all it occurs, it is non-allegoric, but ATN can occur in the setting of shock. So the management is like the initial studies have shown that the mortality was very high, up to 85%. But the treatment is urgent and immediate delivery of the fetus. After delivery, there is complete liver and kidney recovery in most of the cases. So distinguishing among these entities, it's challenge most of the time. So distinguishing between AFLP versus HELP, it's basically of academic interest because as we know, the treatment of HELP as well as AFLP, both are like in severe cases, it is delivery of the fetus. So it's not of much importance clinically, but these are some of the clues. One is coagulopathy, hypoglycemia, they are features of AFLP. When there is severe transaminitis, it suggests AFLP. But in AFLP, thrombocytopenia is only mild, whereas there is severe or mild to severe thrombocytopenia in HELP. But this differentiation, distinguishing between TTP HUS as well as HELP, this is clinically very important because the management of both are different. Because for HELP, the management is delivery, whereas for TTP, management is plasma exchange, whereas for HUS, plasma exchange or eculizumab is a treatment. So this distinction is very important. So what are the clinical points? One is like, just look at these points. One is like in HELP syndrome, the coagulation abnormalities like high fibrinogen level, all these are present, whereas the coagulation abnormalities are usually not present in TTP or HUS. And there is normal hepatic transaminase in HUS or TTP with isolated LDH, whereas hepatic transaminase levels are moderate to severely increased in HELP syndrome. So this slide is very important. I'll be just discussing this. One is HELP syndrome, AFLP, atypical HUS, and TTP, the differentiation. The time of onset is very important. HELP and AFLP happens in third trimester. Atypical HUS typically happens in the postpartum period, TTP in the second trimester and third trimester. Hypertension is present in 80 to 100% of HELP, in 25 to 50% of AFLP, and atypical HUS, whereas it's absent in TTP. AK is only mild to moderate in HELP and AFLP, whereas AK is severe in atypical HUS, and 76% of the AK can progress to ESRD in atypical HUS. Whereas the CNS findings are dominant in TTP, whereas it is absent in all the other. HELP can have some CNS findings. And looking at the serum ammonia is very high in AFLP, where it is normal in all others. And about the management, it is supportive measures or delivery in HELP as well as AFLP, plasma infusion or exchange, or eculizumab in atypical HUS, whereas it is plasma infusion or exchange in TTP. And about the effect of delivery, HELP as well as AFLP can cause complete recovery, whereas atypical HUS as well as TTP does not have any effect on the delivery of the fetus. So that's about the pregnancy specific condition, and just describing about the puerperal sepsis. So according to WHO, puerperal sepsis is a genital tract infection. It can happen anytime after the rupture of amniotic membrane and labor or 42 days postpartum. And for diagnosing this, two or more of these conditions has to be present: fever, pelvic pain, abnormal odor of foul-smelling vaginal discharge, and delayed uterine involution. The major causes are prolonged rupture of membrane, obstructed labor, and frequent vaginal examination. So management is as like any other cause of sepsis: appropriate antibiotics, removal of the underlying source of infection. Next is about renal cortical necrosis. So this is a rare condition. It results from severe reduction of renal perfusion. This is due to vascular spasm, microvascular injury, or intravascular thrombosis. So pregnancy complications. So in around 50% of the renal cortical necrosis cases, pregnancy is the cause. They include placental abruption, placenta previa, septic abortion, prolonged intrauterine fetal death, amniotic fluid embolism. Why this is pregnancy is a condition which is prone to cause cortical necrosis? This is because pregnancy is basically a hypercoagulated state. There is increased level of coagulation factors. There is repressed fibrinolytic state. If along with this additional trigger happens in the form of infection or some hypotension or volume depression, it leads to a complex of series of complex vasomotor and humoral phenomena, which results in thrombosis of the arterioles. And the presentation is like abrupt onset of oliguria, gross hematuria, flank pain, hypotension. So basically the diagnosis is depends upon the CT. It's a most sensitive imaging modality, something called reverse rim strain, where when there is opacification of the renal cortex is absent and enhancement of medulla. And the prognosis depends upon the extent of necrosis, duration of oliguria, and the severity of associated conditions. So the cornerstone of management is to restore the hemodynamic stability, dialysis if indicated, and treatment of underlying diseases. But the thing is that not all patients with renal cortical necrosis have full renal recovery, and it depends upon the extent of necrosis. And just a word about the pyelonephritis. According to ACOG, they asked to conduct routine screening for bacteriuria at the first prenatal visit itself. This is because untreated bacteriuria leads to low birth weight and preterm delivery, whereas its eradication reduces the incidence of pyelonephritis and improves fetal outcome. So early aggressive treatment has to be done. Appropriate antibiotics are crucial. This has significantly reduced the incidence of pregnancy AKI. And the treatment consideration, two things I would like to mention. One is nitrofurantoin as well as trimethoprim sulfonamide. Nitrofurantoin should be avoided in G6PD deficiency as well as in the third trimester because there is theoretical risk of hemolytic anemia in the fetus. The next thing is like trimethoprim sulfonamide. So trimethoprim has concerns of neural tube and cardiovascular defects in the first trimester. Sulfonamides carry the risk of increasing unborn bilirubin, so it can cause fetal jaundice. Hence, the use of trimethoprim sulfamethasone should be avoided in both the first as well as third trimester. So this is in nutshell of what I have told till now. First trimester, the causes are septic abortion, hyperemesis gravidarum. Second trimester, third trimester, and postpartum period preeclampsia help, TTPHGOS, acute fatty liver of pregnancy, or some pre-existing lupus nephritis or APS. So these are two studies I would like to mention regarding AKI in pregnancy. This study is from Madras Medical College by our Gopalakrishnan sir. This was published in May 2015. In this particular study, there was 130 patients were studied. The incidence of AKI was 7.8 percentage, and most of the AKI here was not in the postpartum period. That is 68 percentage was not in the postpartum period. In this study, the most common cause was sepsis in 39% of the cases, followed by preeclampsia in 21%, followed by placental abruption, followed by acute diarrheal disease, and it was followed by thrombotic microangiopathy and PPH glomerular disease. And in this 130 patients, they did biopsy for 46 patients. And biopsy, the major biopsy finding was renal cortical necrosis in 16 patients, followed by TMA, followed by acute tubular injury, followed by acute tubular interstitial nephritis. And it is found that 34 patients were managed conservatively, while 96 of these 130 patients required dialysis. And among this, complete recovery was occurred in 56%, whereas 36% had persistent renal failure at 3 months. There is another study by Manisha Sahai madam. This was published in 2022. Here, a total of 395 patients were studied. The mean age was 27. Here, in contrast to sepsis, preeclampsia was found to be the most common cause of AKI in 44% of the patient, followed by puerperal sepsis, followed by hemorrhage. And among these 395 patients, they did biopsy for 103 patients. And the biopsy findings are also interesting. There is some form of cortical necrosis, patchy cortical necrosis in 26%, and in 24% of the patient, diffuse cortical necrosis. So in approximately 50% of the cases, cortical necrosis was a major finding in biopsy, followed by acute tubular necrosis, followed by acute interstitial necrosis, and TMA accounted for around 9% of the cases, followed by lupus nephritis, MPG, and other glomerular diseases. So from this, 76%, that is 290 patients required dialysis, but the outcomes were good because, as I told, preeclampsia was a major cause. So around 76% improved, whereas 8.3% of these patients progressed to ESRD. So with this, I wind up my talk. Thank you.